Okay, I believe it was stuck, so we start. I'll continue from where I was. I hope it was seen by all. Now, in the Southeast Asia region, 30% of the population live in areas with moderate to high risk of malaria, mainly in India, Myanmar, and Thailand. Well, not that Pakistan doesn't have, Bangladesh doesn't have. We are looking at population wise, so that's the reason why we have not quoted all these other smaller countries. Threat of drug resistant falciparum, from monoresistance to multi-resistant drug resistant, is present in the area, and 400 million people at risk of acquiring drug resistant malaria. Drug resistant enhances the morbidity and mortality and increases the treatment cost. So you can see over here, as I was saying, that you have all the countries which are there are they have got this thing, but we are the maximum. India is the maximum. Why is Pakistan not here? Pakistan doesn't come in Southeast Asia region. That's why. Globally, India is the third largest contributor to total malaria cases and deaths. In the Southeast Asia region, 70% of total malaria cases is by India, 69% of total malaria deaths. This is the 2015 World Health. Things have dramatically improved in the past few years. We'll talk about it. 86% of the total population is at risk. Proportion of total malaria cases, India has 7% of the world's cases which are there, and 4% of the deaths. This is we already covered. Economic cost. The biggest problem with malaria is a disease of poverty, where people can't take any protection. So it is a disease of the poverty, and it also results in further poverty. A major constraint of whenever there is development is taking place, wherever there is construction taking place, malaria occurs. So the development gets constrained. Annual economic growth in countries with high malaria transmission is lower than countries without malaria. This is a problem where it's in poor countries, and malaria itself then causes problems. It decreases the what is available in the pocket. See, you can just see. Now, if you start looking at world poverty and malaria, it is almost similar. Almost similar. Look at the malaria burden, the blue, and look at this brownish or brownish red, which is there. You will find that poverty and malaria go together. Well, in 2009, we had 2 billion cases and 1,000 deaths. I want you to just look at these figures. 2 million cases, 1,000 deaths in 2009. We had, if you look at 2000, we had almost about 5 million cases, 5 to 10 million cases in 2000, came down to 2 million in 2009, and now we are in lakhs. We have got 3 lakh cases which are there, which I'll show you a little later. Andhra Pradesh, Maharashtra, Madhya Pradesh, Rajasthan, Chhattisgarh, Gujarat, Jharkhand, and Orissa. These are the places which are high incidence areas. So here we are, 2.3 million cases which were there in 2009 rather. And 2015 you had 1 million cases. And 2019 you have got 3,38,500 cases. And there are only 77 deaths which have occurred of malaria in 2019. I'm not taking 2020 figures. 2020 is dedicated to COVID. So the figures in as far as in 2020 you get only figures for COVID. You don't get figures for anything else. You can't really compare 2020 with the rest of this thing. You can't say that our control measures are so good that we have got so less cases. Oh, the reasons are quite different. So earlier also we had a decline in the number of cases from 1976 to 1984 when we had the modified plan of operation. Since then there was no decline which was taking place, and since 1997 there was again a declining trend. And then from the 2000s the trend has again started declining. Currently there's a serious problem in the northeast because there is a lot of falciparum malaria there, and as I said, these states, major endemic states we've already mentioned. Okay, what are the agent factors? There are four distinct species: vivax, falciparum, malariae, and ovale. In India, vivax and falciparum, malaria and ovale do not occur in India. But if you're trying to look at the various species everywhere, then vivax and falciparum are the ones. Malaria occurs in some cases. So, what are the different types of epidemiological types present in India? One is the tribal malaria. You see, the when you go into the rural areas, wherever there are tribes, there it is more difficult to control because these people stay in forested areas where there's a lot of mosquitoes and it's difficult to control, difficult to push into action many of the programs in these tribal areas. So, infants, young children, pregnant women, followed by a mobile tribe population, are the high risk groups. And there's limited health infrastructure, there's lack of drugs, high morbidity, and mortality. So, one, tribal malaria. Second is rural malaria, where there's moderate to low endemicity. We have the main vector is Anopheles cunicifacies. Again, health infrastructure they say is moderately developed. You generally don't find the COVID situation has brought into highlight what the problem of the health situation in the rural areas. And I hope things will improve after COVID. Urban malaria, which contributes to 80% of cases, covers under the urban malaria control scheme. This is something because of construction, etc. We have large number of collections of water. Then project areas, again, construction and developmental activities, temporary tropical aggregation of labor, border malaria. See, what happens is one state covers their zone and the other state covers, if there is a difference in what they are doing, the border areas are generally left out. So whether it be border areas of states or border area of districts or border areas of cantonment, of the municipal corporations, all these border areas are the ones where nobody takes any action, and that creates problem because of the population mixture and poor administrative control. What are the ages involved? Mostly all ages. Newborn infants generally have a resistance towards falciparum. Males are more at risk because of the fact that they go out more. The sickle cell trait which is there, any person who's having a sickle cell trait, the disease becomes milder. Why is it so? Nobody is able to answer. Duffy negative RBCs are resistant to Plasmodium vivax. Why? Very difficult. Nobody has been able to answer. But Duffy negative is resistant to vivax, and sickle cell trait have milder disease. Gravidas, intrauterine drug users, premature labor, or abortion, all these people are high risk groups. Socioeconomic development, low socioeconomic group people are the ones who can possibly get the disease more. Ill ventilated, ill lighted rooms, sites which have constructions which are now. What is the site and what is the type of construction or what is the nature of the walls? These all will influence the selection of control measures. In control measures, one of the important control measures is to spray insecticidal residual spray. That you spray on the walls. Now, if your walls are made of mud, then the resistance, the amount of that the chemical will possibly stay on will be less, because there is a likelihood that these people will again put more mud on the walls and will cover the, the chemical which has been used. We talked about population mobility earlier also due to wars, but otherwise also in our country where you have so much of migrant labor. Migrant labor is a big problem in our country, and this migrant labor carries the infection or carries the infection from an endemic location to their villages. So a lot of problems which is there with migrant labor. The people for in our country we are got a mostly agrarian society with the rural backdrop, and so the chances of them not taking personal protective measures is high, and that's the reason why transmission is higher. Also the habits. There are a lot of people in the villages who sleep outdoors. There are nomads who take the various gatherings of sheep, etc., to village or various other locations. They sleep outside. Refusal to accept spraying of the houses. A lot of people say we don't want to spray our houses. Not using methods of personal protection like bed nets, etc. This is very, very common. So all these can result in transmission. Immunity, the collective immunity comes into play. You have to have herd immunity, and herd immunity is not present in our case. Herd immunity is lacking in it, and immune mothers, they will transmit immunity to their infants, and so 3 to 5 months the infant is immune. When we say this person is semi-immune, means partially protected, or many a time immunity is species specific. So you've had bivax infection, you can still get falciparum infection. The humoral and cellular responses help in the protection. Now, we do find that season has a big effect. Basically, why so? The reason is that you require water for transmission for breeding. And when you have the water rains coming on in the month of in the month of June, after that there's a lot of water available for breeding, and that's the reason why the transmission season is from July to November. Temperatures, optimum temperature is 20 to 30 degrees with a relative humidity of 60%. Rainfall has got variable effect. For example, if you have very heavy rains, then breeding is not possible because there is overflowing water and the breeding does not take. So in places where there is very heavy rain, you will find, especially in coastal areas, during those months when there is very heavy rain, mosquitoes are less. But once the rain stops, then the mosquito breeding takes place. Now, Anopheles mosquito is not seen about 2000 2500 meters, but not really so. Now we are finding that they've reached there also, adaptation has taken place. Man-made malaria, the humans create conditions which will help, like for example excavations during construction or various other places where water collections can take place. Okay. These are the states which have the maximum number of cases which are there: Odisha, Chhattisgarh, Jharkhand, Madhya Pradesh, Maharashtra, and Tripura. Andhra, Telangana have moved out because of very effective control measures, though they were labeled earlier. Um, factors which are there for high endemicity is inaccessibility in various areas, forest and fringe forest areas, ethnic population, poor health infrastructure, an efficient vector, and conflict areas. So, as you see, the amount of cases of malaria is going down. We have had very interesting changes which have occurred. We have put into place things like artemisinin, which has come into use from 2000, say 2005, 2006. So there we had a drop. Then we started using long-acting impregnized nets. So that also we did get a little bit of a drop. And then we have rapid detection kits now today. So cases are detected early, and hence they are you can treat them early so that they don't produce gametophytes so for further propagation of the disease. Okay, the extrinsic and intrinsic factors, you have the social, behavioral, economic, and political factors, along with the environmental factors. You have the human, the parasite, and the mosquito being involved, and that can all be controlled with control and preventive measures, which we'll talk about. We already mentioned this. Okay. What is a vector for malaria? The vector for malaria is the female Anopheles mosquito. The female Anopheles mosquito has 45 species which can transmit the disease. But it is mainly in India, it is Anopheles culispacis, which is there in the rural areas, and Anopheles stephensi, which is there in the urban areas. And which are the factors which involve this critical density of mosquitoes which is required for the transmission of disease. The lifespan is 10 to 12 days. So that's the reason why we can always control them if we are able to control their lifespan. Sorry, 10 to 12 days after a blood meal. After a blood meal. So one has to ensure that the mosquito is killed before that. Uh, we do also have Anopheles fluviatilis, which is a anthropophilic, that means loves humans. Now, this Anopheles fluviatilis, which I was mentioning about, breeds also in moving water, and that is a big problem because if you are moving water and some mosquito breeds in that, difficult to control. Mosquitoes generally bite at night, and the capacity of the vector depends upon various factors which you already mentioned. You would also consider whether the human being, the mosquito is resistant to insecticide. The mode of transmission is, of course, through mosquito bite, that's vector transmission. You can also have direct transmission through blood or plasma of an infected person. And third is congenital malaria, where the mother gives it to the child due to poor resistance. Now, this is very, very important to remember the life cycle of Plasmodia. Now, the life cycle of Plasmodia is, if we want to discuss about how to treat a patient, or how are we going to control the disease, we must know the life cycle. And in this, if I may just point out, if you see the arrow, can you see the arrow? Okay. Now, we will start off with the mosquito biting the human being. And then the mosquito, or let's start off when the mosquito bites the human. Okay, when the mosquito bites the human being, he injects sporozoites. And once these sporozoites go into the liver cell and there's the liver stage of the disease, which is also called the exoerythrocytic stage, outside the erythrocytes, so exoerythrocytic phase, where you have infected liver cell and a Shy-Joint form, the rupturing of the Shy-Joint, where you have the where you have the chison rupturing and it entering the erythrocyte. Now, once it enters into the erythrocyte, there's a trophocyte stage and a chison as well as a ruptured chison, again the merozoite forming. Now, once the merozoite comes into circulation, there is clinical features coming on. Now, during this process of trophozoite, many a time you have the formation of the sexual stage of the disease of the mosquito, that is the gametocyte, the male and female gametocytes. And when the mosquito bites, the male and female gametocytes are taken up, they go and become a oocyst or ookinete, and then you have the macrogametocyte, microgametocyte, and then the oocyst formation, and the oocyst then um, ruptures to form the sporozoites. Okay. So this is what is the complete life cycle of a plasmodium. Please remember this because each of the drugs is effective under a particular stage of the disease of the life cycle. So when we have these four species, what is the type of fever which takes place? Vivax, falciparum and ovale give a tertian type of fever, while malaria gives a quartian type of fever. Quartian is 4 days, tertian is 3 days. So generally 3 in the sense it comes in 2 days. Okay, every alternate day it comes. Plasmodium vivax, discovered by Grassi and Folletti, falciparum by Welsh, malaria by Lavaran, and ovale by Stephens. Okay. Okay, let's just discuss a little bit about the various stages. Malaria is transmitted by bite of the infected female Anopheles mosquito. During feeding, mosquitoes inject the sporozoites which circulate in this thing. We have already discussed all this. Merozoites released from the liver go into the erythrocytes, the asexual erythrocytic phase, and then you will have the merozoites again forming off and the clinical features coming on. Then you can, because of the merozoites, you have the clinical attack which takes place. And from the erythrocytic phase, once you have had few cycles of this erythrocytic phase, then you will develop the gametocytes, and the gametocytes will be taken up by the mosquito, and you have the oocyst formation, and so that is how it is. Again, another photograph which shows the various. Now, please remember that Vivax and falciparum have a different mode of so when you find that the in Vivax you have a persistent hepatic stage where the after the rupture from the chison stage, the reinfection of the liver cells takes place, and we have it persisting in the liver. Again, gametogenesis occurs in mosquito gut where there is exflagellation. The gametocytes activating factor in the mosquito. I will not go into details, not necessary for y'all. And also sporogony occurs in the mosquito, and the zygote formation, the ookinete. We will not talk about this. I think we can just run through this. We don't require it. This is for the postgraduates. We'll discuss this in detail with the postgraduates. Okay. You have to have, for the mosquito propagate, you have to have both sexes of the gametocytes. They have to be mature, they have to be viable, and with sufficient density. And the period of communicability is as long as mature, viable gametocytes exist in the circulating blood in sufficient density to infect the mosquitoes is the period of communicability. And the relapses can occur up to 1 to 2 years from Plasmodium. Now the host factors also include, we have already mentioned some of it. Yeah, we have already mentioned all these things, I think. This is a copy. Okay. This is also duplicate slides. Yeah, this has also been covered. Okay. Now, how do you measure? It's very important that we talk about how we measure malaria in the population. We will talk about clinical features, etc., a little later, but how do we measure malaria in the population? Magnitude of malaria cases determined from the reports of clinically diagnosed malaria cases. So, and the malaria-metric measurements which are there are the spleen rate, the average enlarged spleen, the parasite rate, the parasite density index, infant parasite rate, and proportional case rate. Let me see if, yeah, I have details about it. Now, in spleen rate, it is the percentage of children between the ages of 2 and 10 years who are showing enlargement of spleen. Please remember that enlargement of spleen is felt only and only when the spleen enlarges 3 times. Spleen enlarges 3 times, that is the only time that you can feel the spleen. So it's a huge enlargement of the spleen already. So you do the study in children because you want, if the children are 2 to 10 years old, we know that it is from a fresh infection that these things are taking place. In adults, we don't know when the spleen had enlarged. So this is used for measuring endemicity of malaria in their community. Then you look at the average enlarged spleen, denotes the average size of enlarged spleen. Then the parasite rate, where the percentage of children between the ages of 2 and 10 years show malaria parasites in their blood film. Parasite density index, that indicates the average degree of parasitemia. Only positive slides I quote in this denominator. Then, very important, the infant parasite rate, that is the percentage of infants less than 1 year showing malaria parasite in their blood films, is the most sensitive index of recent transmission. That recent transmission is. If the infant parasite rate is 0 for 3 consecutive years in a locality, it is regarded as absence of malaria transmission. Though the anopheline vector is responsible may remain, but the transmission has stopped. Now, also consider what is the proportional case rate, where the number of cases diagnosed as clinical malaria for every 1,000 patients attending the hospital and dispensaries. The crude index, it's a crude index because cases are not related to their time and space distribution. Now, this was earlier we used to consider. Now, during the eradication phase, we have these particular indices which you must consider. One and most important, annual parasite index, annual blood examination rate, annual falciparum index, slight positivity rate, and slight falciparum rate. It's very simple, most of them, but I'll just run through this. The annual parasite index is the number of confirmed cases during 1 year divided by population of disease. So total cases divided by population into 1,000. Very, very simple annual parasite index. So this is a very important index and we keep on using this index whenever we talk about malaria control. The second is annual blood examination. How many slides have been examined? Number of slides examined divided by the population. Maybe that you're not examining at all, you will not get positive. So number of slides with divided by the population. And it determines the operational efficiency of this particular center. Also depends on the amount of blood which is collected. Now the other indices which are there are human blood index, which indicates the degree of anthropophilism. You see human blood indexes, you take mosquitoes and check how many of them got human blood in them. So that's a measure. Sporozoite rate, that's the percentage of anopheles with sporozoites in their salivary glands. You see, what was Donald Duck doing? He was taking mosquitoes, dissecting them, getting, finding out whether they had sporozoites or not in the salivary gland, dissecting the salivary glands as well. So it was a tedious process, but it is well paying. Mosquito density, number of mosquitoes per man hour. Now you're catching mosquitoes, and when in 1 hour, how many mosquitoes you catch? That is called per man hour catch. Or you put a human being without clothes and you let the mosquitoes bite, and then you keep on looking how many mosquitoes have bitten, try and collect those mosquitoes. So that is man biting rate. And then is inoculation, man biting rate into infectivity, infective or sporozoite rate. So both these things together. Okay, I will stop here for the day. We'll talk about clinical features next time. Um, and please read up. Please read up about malaria and preventive aspects about malaria, and come up with questions. Unfortunately, in YouTube, we can't have interactive session. I hope that by next time they will move to Zoom so that we'll be able to interact with you. Okay, thank you. All the best.